So everyone knows you're being recorded now, and if you need this recording, you can request it by emailing one of us, and our emails will be at the end. Or if you are in contact with Connie Bracey more than you are the three of us, you can also request it from her, and we can get you that. Or if you have a friend or a colleague that you knew was supposed to attend tonight, they didn't get to, just have them reach out, and we can share it as well. And the last thing is the certificates of attendance. So when you complete session 1 and session 2, we will be sending those certificates out. And you can look for that from Connie or one of us, however it needs to be done whenever the time comes. If anyone has any questions, just please feel free to drop them in the chat and one of us will take care of you. So like I said, we work for Partners for Inclusive Communities, or what we like to call partners since it's a mouthful. We are Arkansas's USED. Every state has a USED. So this is the University Center of Excellence on Developmental Disabilities. We have our vision and then kind of what we do. We pretty much work with people across the state in order to bring access and inclusion to individuals with disabilities within Arkansas. And we will share all of our socials and website at the end if you want to learn more about us. Okay. We're still at about 20 participants, but that's okay. We're going to go ahead and get started since it's 6:06. So our first question for everyone is, what does FASD stand for? This acronym is sometimes referred to as one thing and not the other, so we're going to set the record straight and kind of dive into that. So FASD stands for fetal alcohol spectrum disorders. And I want to repeat that because oftentimes people will say, oh yeah, that's fetal alcohol syndrome, which there's some relation there, but it's not the same thing. So it's fetal alcohol spectrum disorders. If you're catching on to disorders, you're going to learn that there is more than just one. So that brings us to this beautiful graphic of the FASD, or the fetal alcohol spectrum disorders umbrella. So FASD alone is not a diagnosis that a doctor or any other kind of practitioner can give you. As of right now in our world that we live in, you're not going to have FASD written on your paperwork with a diagnosis code. That's just not how it works. So these are the specific diagnosis or diagnoses really that an individual could receive if they have an FASD. So each of these would be put on paperwork. There's a diagnostic code that goes with it. And there's criteria in order to have these diagnoses. Tiffany, Leslie, and myself, we diagnose NDPAE, and we are also training practitioners all across the state on how to identify and diagnose this disorder as well. So what all does FASD affect in terms of someone's brain? Maybe you thought it could be one of these things, but in reality, it could be one or more of these things. And as you can see, it's not just it's not just how they talk, or it's not just how they think or things like that. It's a combination of many, many things. Whether it is how they communicate or how they focus, or maybe how they work in the workplace environment. Maybe it's how they are in your classroom or at school, sensory and motor and things like that. So it's not just like oh, you have FASD, here's the one problem that you have. It could be one or many of these things because it affects multiple areas and processes in the brain. So I will shift gears to Leslie.
Okay, so Natalie's kind of given you an idea of what FASD is. So now we're going to talk about how common is FASD. And it's a little hint for you. It's a lot more common than you probably think. And so we're going to kind of talk about the percentages and the prevalence. If you want to take a guess, you can stick in the chat what your guess might be, but you might be surprised. Go to the next. So, a study has shown that the conservative estimate for FASD is about 1 in 20 or 5% of the population. However, there's additional information and analysis in that same study that had researchers propose that the weighted or more realistic estimate is really 1 in 10. So very, very common. The article was published in the Journal of the American Medical Association in 2018, and they looked at 6,000, actually 6,500 first graders in 4 different US communities. The most conservative estimates for FASD, as I mentioned, was 1 in 20. But when they applied this rate to the remaining first graders in each community who were not evaluated, the overall estimate ranged closer to like 9.8%. So only 2 of 222 children out of those that were identified by the study's research actually had already been diagnosed. So 2 out of 222 students, or yes, 222 students had an FASD diagnosis. So there were 220 of those that had not been identified. The study states that misdiagnosis and misdiagnoses of children are common. And the main reason that we find that this is not diagnosed or misdiagnosed is the stigma or the lack of recognition of FASD. So one of the most difficult aspects of any research on fetal alcohol spectrum disorders has been gathering accurate, honest, and detailed information on the specific drinking patterns and the actual or estimated blood alcohol concentration levels and linking them to exactly when they were exposed in that time in utero. So information on specific prenatal drinking behaviors that are the necessary cause of an FASD has been elusive, and this in fact has limited the ability to determine the true prevalence of FASD more than any other factor. So what about in foster care? We can look at the foster care population and see that an increase in children that have been prenatally exposed to alcohol is actually about 70% of the foster care population. So it's really important with these children to try to get as accurate of a history as you can and keep that on the radar for these providers that are seeing these children because it's very likely that they could have been exposed to alcohol prenatally. So it's also been found in studies that 1 in 5 individuals in the prison system meet criteria for an FASD, which is very interesting. And this shows that, not to stigmatize, but it shows that there is a problem and it shows the consequences with underdiagnosis and misdiagnosis, because all these people did not get the treatment or services that they needed because they were missed. And so it can lead to legal issues down the road. So it does have a huge effect when these individuals are not identified. So autism, everyone's heard of autism, right? So recent data from the CDC has been published that informed the general public of a change in the prevalence of autism. It used to be 1 in 44. Now they're saying about 1 in 36 individuals in the United States have an autism diagnosis. So we can now see that FASD is more common than autism by almost 2 times. However, we would bet that if not all, you have heard of autism or know of autism, but can everyone say that they've heard of FASD or know about FASD? So it's definitely an issue. So we have a problem. Less than 1% are actually being diagnosed with an FASD of those that actually have the disorder. So that's as Natalie mentioned earlier, what our team is currently working on is spreading that education throughout the state of Arkansas, training those providers around the state on how to recognize, how to diagnose, so that we can get that percentage up.
Well, it brings up a lot of questions for us, right? If FASD is so common, I mean, we're talking like 5 to 10% of the population. So that's 1 or 2 kids per classroom. Why aren't people being diagnosed? Why are less than 1% being diagnosed? And why doesn't everyone know what FASD is and what it stands for and what it means for kids? Yeah, so I saw in the chat hidden issues. That's a really, really great one. We're going to cover that one as well. That's absolutely it. So one of the problems is that FASD can sometimes be misdiagnosed as a mental health disorder. Now, this isn't to say that if you have a child that has ADHD and FASD, their ADHD diagnosis just doesn't exist and doesn't matter anymore, right? You can have multiple disorders at the same time. But if you look at this chart, you can see some things that are common between FASD and some of the mental health conditions. So very commonly in clinic, we'll see kids who come in with multiple mental health conditions, and we think there's got to be a reason for this, right? There has to be an explanation of why this one child has so many different mental health diagnoses. And sometimes it is because they have an FASD. Stigma is a major barrier to diagnosis. Stigma runs rampant in the world of FASD. So many healthcare providers are really uncomfortable considering the diagnosis of FASD, and parents might also be really uncomfortable with giving their child a label of an FASD because of the stigma. Sometimes history of prenatal alcohol exposure is not shared. This could be because of stigma. It could be of concern of judgmental responses. And sometimes it's worry that if we disclose our use of prenatal alcohol exposure, that our children could be taken away from us. History might be unknown. So this is particularly true for children in the foster care system or those who've been adopted. We might not know if they've been exposed prenatally to alcohol. Sometimes alcohol use just isn't seen as important as some drug use. So people like healthcare providers will ask about drug use, and a mom might say, yes, I use whatever illicit substance. And then that's the end of the conversation. Because a lot of times we think drug use is so like bad that we think alcohol use isn't nearly as big of a problem to consider, when actually it's the opposite. Alcohol is one of the strongest teratogens, and so it's actually one of the things that we should most definitely be asking about, but sometimes we don't. This goes to what you said in the chat, so you were right on top of it. It's an under-recognized condition. So providers might just not be aware that FASD exists, or that you can have an FASD without facial features, which we'll cover in a little bit. So it might just not be on their radar. And this isn't to say anything bad about providers. Providers have a lot to know, and FASD is really unknown across the spectrum of providers, not just like primary care doctors. And then lastly, there's no specific test. So you can't come in and get, say, like a blood test, and I can tell you yes or no, you have an FASD. There's not one specific easy way to diagnose the condition. Okay, so here's a statement for you. Everyone with FASD has facial features. Is that a myth or is that truth? Anyone want to put in the chat? Anyone feeling brave? Myth. Yes, Leslie. Yep. Yep. You guys are good. Yes. So this is a myth, right? We talked about this a little bit. Only 1 out of 10 people with an FASD actually have facial features. So that means 90% of the time, a child or an adult with an FASD has no facial features at all. So as a reminder, these are the diagnoses under the FASD umbrella, and one of those is FAS, or fetal alcohol syndrome. People with fetal alcohol syndrome have the neurocognitive symptoms, but they also have facial features. The other diagnoses that are under this umbrella have no facial features. So what are the specific facial features? Well, here's three really cute kids that all happen to have fetal alcohol syndrome. And like it says, only 1 out of 10 will have the facial features. So the first one is small eye openings. So if you measure one corner to the other corner of the eye, that area is narrow. So smaller eye openings. The second one is a thin upper lip. So it's called the vermilion border is the fancy medical term, but it's basically like where you would put lipstick on your upper lip. That area is very thin. And then the last one is a smooth philtrum. So philtrum is just a fancy term for the groove that's between your nose and your upper lip. That kind of divot groove that everyone has tends to be smoother in people that have fetal alcohol syndrome.
Okay. So we've talked about what FASD is and the umbrella and the prevalence and what is kind of stopping us from addressing the less than 1% that is being diagnosed. But the other part of this is how much alcohol exposure when a woman is pregnant or with child, developing the child, would put that child at risk for an FASD. So some like three kind of questions if you're kind of trying to get an idea in your head on what you think. Do you think it's a certain number of ounces that she has consumed? Do you think it's a certain number of drinks at one time? And y'all can also send this in the chat just to kind of, put your opinion out there and see if you're right. Or do you think it's a number of drinks within a certain period? So maybe that's like all the drink, a certain number of drinks in the 40 weeks that she's pregnant, or this number of drinks in a month, or this number of drinks in this trimester. So if you have an idea of what you think the rule would be, let us know. But those are just some kind of like jumping off points to kind of get you thinking if you might have an idea. Oh, okay. Some of you have been doing your research. Okay, I like it. I like it. So, according to diagnostic criteria, and this is what we follow, and it's from the DSM-5. If you're not familiar with that, that's okay. It is a diagnostic manual that is put out for practitioners to use. Tons of research, all the things to back it. But it pretty much goes through all these diagnoses and what symptoms look like for these specific diagnoses, and then how does a provider, diagnose it. So if you were to be diagnosed with an FASD or someone you know, one of the criteria would be minimal levels of prenatal alcohol exposure. So that's why we asked that question, because there's two options here. So the first one would be more than 13 standard drinks, and we will talk about what that actually means next. 13 standard drinks per month while a woman is pregnant. So in any month of her pregnancy, if she had 13 drinks in that 1 month, then that would meet criteria. So if you're someone that enjoys a glass of wine every night before bed, if you have one glass, but maybe you've had it every night for 2 weeks, you would meet criteria for that. The other option, remember I said there's two here. This is the one that really gets a lot of people freaked out, honestly, or maybe gasp and be like, oh my goodness. It's 2 standard drinks at one time. So if you're somebody that loves to go to dinner and get a cocktail or an alcoholic beverage, if you order one when you sit down and then you order another one whenever your food comes, that counts. Maybe you're somebody that likes to socially drink, and so maybe you're at a watch party for a football game since it's football season. That's a long time to be sitting there watching something on TV. You get one beer, maybe at halftime you get a second beer. There you are. You have exposed for the minimal level of prenatal alcohol exposure. So, like I said, I kind of gave a little teaser there. Standard drinks. This is not what you think. And it's not what it's not what Texas Roadhouse or your local Mexican restaurant is serving, I can assure you, because not many times do I see a bartender get out a measuring cup and measure 5 ounces of wine. And I certainly don't see bartenders, making sure it's 1.5 ounces in the shot glass. It's like they're just throwing it together kind of thing. So here are your standard drink measurements according to wine, beer, and then liquor. And this is also based off of the DSM-5 criteria. So if you have 2 of each of these at one time, that's minimal levels of exposure. So if I had 2 glasses of wine that were 5-ounce pours and they were 12% alcohol, that would be a standard drink, or that would be, sorry, minimal levels. 2 12 ounces of beer that is 5% alcohol would be minimal level. And then if I had a shot or 1.5 ounces of liquor, and this is like 40% alcohol, but typically liquor is what's referred to as like proof. This would be an 80 proof shot or 1.5 ounces of liquor. The thing is, a lot of times that people ask us is, okay, well, does that mean that tequila is worse or more harmful than Miller Lite? There is really no study that's like, oh yeah, this one's better than this one. The research shows us right now that any type and any amount, in terms of if you have a little bit more of this one and not as much as that one, any type of alcohol is detrimental to the central nervous system or your brain and your spinal cord development. So our rule is there's no safe amount and there's no safe type, which we'll talk about here in just a second. But just to give a statistic, in the past 30 days, a study was done to collect data in the past 30 days at that time. 1 in 10 pregnant women consumed alcohol. And if you have 10 friends or you were recently at a birthday party and 10 people were there, that kind of thing, that's a really small circle. The other one is 1 in 33 pregnant women reported binge drinking. Does anyone know the definition or like amount that is classified as binge drinking? I know like in your college days, it's probably like, oh, you just drink until you can't anymore, but there is actually a number for it. Okay. Okay, yeah. 4. 4 drinks at one time. So, like we were talking about earlier, it's fall, bonfires, football, the holidays are coming up. This past summer holidays when you're at the lake or you're at the beach or on vacation, or maybe it's just summer, maybe you're off work kind of thing. It's really easy to have 4 drinks at one time if you're in that kind of setting. And that's how you partake. So 1 in 33 pregnant women reported that they were having 4 or more drinks at one time. And then 1 in 10 were just consuming alcohol, point blank, period. All right, switching it back to Leslie.
Okay, so myth or truth, alcohol in early trimesters is okay. So some people say drinking early in pregnancy is okay, or they have the saying of drink before it's pink, meaning you can drink before you get a positive pregnancy test. And then some people say that drinking late in pregnancy after the baby is formed is okay. And I noticed that someone had put in the chat that their OB had told them that it was okay after 20 weeks, and that is not the case. And so we've really got to get out and educate the community and providers as well that no amount of alcohol at any point during pregnancy is safe. And what's really scary about that is, and we'll get to that in a couple of slides, is about even before we know we're pregnant. So definitely a myth. It is very easy to expose a pregnancy to alcohol. And it can happen even before those pregnancy symptoms start. So even before you start getting nauseous, you have a positive test, that damage can be done. And it's so important to remember that the birth mother is not to blame, that it's the alcohol that's not to blame, that is to blame, to help with that stigma. So alcohol consumption, again, at any point during the pregnancy can cause issues. The brain develops throughout the pregnancy, and this kind of little graphic shows you that it starts early in development, even as early as week 3 when we start having the central nervous system developing. So even that early, it can cause issues. And then facial features develop later on. So brain is going to be affected before even the facial features are.
All right, so let's go back a few years, shall we? So we're all sitting here on Zoom. We probably all got really used to doing Zoom because of the COVID-19 pandemic, right? So the pandemic was actually kind of the perfect storm for increasing numbers of kids and adults with FASD. So what we saw is that alcohol sales increased by 35%. By the end of summer of 2020, actually, alcohol delivery sales increased 200%. So that's people bringing alcohol to their home. In 2021 alone, there were 1.4 million unintended pregnancies. So a lot of pregnancies and a lot increase of drinking, which created this perfect storm that increased the number of people with FASD likely. So one of the things about me that we didn't discuss in the beginning, but I have 2 children that have an FASD, and so I have a really special place in my heart for kids with FASD, just like Leslie and Natalie do as well. We're going to talk about some of the features, behavior features that we see, and some of the, problems that we see with kids with FASD. But what's way more important is this slide right here, and it's the strengths of children with FASD. Kids with FASD, and we hear it all the time, are really friendly. They're super likable. They love everyone. They've never met a stranger. They'll go up to everyone and they're their best friends. They're very verbal and easy to talk to. They're really hard workers. These are the kids who in school always want to be the helper. They're very determined. If they put their mind to something, they are going to do it. It might take a little bit longer, but they are going to do it. They tend to be great with small children, older adults, and children with disabilities. They forgive easily. I always say this is like my favorite thing about my children with FASD as a parent, because sometimes you lose your patience on your children, right? And I can just tell my children, like, I'm really sorry for what I did or what I said, and my kids will immediately forgive me, and they don't hold grudges against me. And it's a wonderful, beautiful personality trait to have. They're very trusting of people, and they tend to be really artistic and musical.
Okay. So one of the things that is obviously I have windows surrounding me and the sun has gone down because now I look like I'm a hermit in my room. But one of the things that is so special to me about our clinic is that it's strengths based. So we started off talking about the symptoms of FASD with that strengths based mindset. Whenever kids and families come to us, that's one of the first things that we ask the child, what are you good at? What do you think your strengths are? A lot of times this is hard for these kids, and it breaks my heart because it is that stigma of they're a bad kid. And it's not that they're a bad kid. I always say that their brain works differently and people just don't understand how their brain works. And we'll talk about kind of how their brain works and what that looks like. But it's like you can really tell that for some of these kids, it's the first time that someone has asked them, what are they good at and what do they bring to the table kind of thing, like in a job interview. And then it's also really hard and difficult to see when you ask the parent or the caregiver, what do you think that they're good at? Sometimes it's really easy. these parents have thought about this, but sometimes when you're in a crisis or you're in the trenches, um, or you feel like everyone's like kind of blaming you for how your kid behaves and acts and stuff like that, it does get daunting and hard. So if you have a friend or a colleague or someone that you know that has a child with an FASD, I really encourage you to look for that kid's strengths and look for the strengths in that parent and caregiver, because they need to hear it, just like any other parent and caregiver needs to hear, like, you're doing a good job, or your kid is so great at this, or I love this about your kid. um I know we're all about what FASD is, but that is the real and the raw that we see. It's so rewarding what we do because we can validate these parents that everyone else tells them, like, well, you need to parent harder, or you chose this, like, you knew what you were getting into, that kind of thing. Sometimes it's just, it's that typical saying, if it's cool to be kind, it is cool to be kind, because you just don't know what other people are going through. And these two disorders that we are going to talk about that we diagnose, they're what we call hidden disabilities. So individuals with an FASD, we talked about the facial features and how rare they are. So if there's nothing that shows us that someone has a specific diagnosis or disability, we're probably going to expect them to act neurotypical. But if that disability is hidden, then that's not fair. So we'll get into what that looks like. At the top, I could probably use my cursor so y'all can see. Other specified neurodevelopmental disorder. This just goes into that NDPAE, which was on that umbrella slide that I said we diagnose. That's one of the FASDs. An unspecified is one that we give. It's not an FASD, but it's in this neurodevelopmental family, because a lot of times we give this when we don't have confirmation of alcohol exposure. So, like we talked about, maybe the history wasn't known, or that information wasn't released and things like that. And it might have been suspected, but there was no confirmation. However, you still look for these same symptoms and traits and stuff like that to make these calls. So don't worry if you're like, what in the world? This is not my wheelhouse of words or vocab. We will talk about that. Neurocognitive impairment. So neuro means brain, cognitive also means brain, but really how your brain functions and how it works. This first one. So also what these numbers mean. There's kind of 5 options. There's 3, and then there's 4 within each of these areas. For this one and this one, so neurocognitive impairment and then impairment in self-regulation, you only have to have a symptom or evidence of one of these conditions in this box in order to meet criteria. So we'll go through each one of those. So it's not like, the person that you might be thinking of right now, they don't have to have an impairment in every single one of these. It just has to be one of the 5. So a global intellectual function impairment. This is individuals that have a diagnosis of intellectual disability, or what some people refer to as ID, or a lower than average IQ level. The other one is executive function. This is something I could talk about on and on, but I won't, and we'll kind of save that for session 2. But we are looking for executive dysfunction. This is a very, very common symptom in individuals with FASD. If you don't know what executive functions are at all, that's okay. I'm going to give you a brief definition. So the way I think about it is, everyone loves and knows like their local school secretary or their administrative assistant that pretty much makes the world go round, or makes the workplace go round on a day-to-day basis. So they are making the schedule and problem solving if things come up, and they're communicating with everybody, and they're organized, and they kind of know everything that's going on. They can be typing an email while they're on the phone with someone else, doing 2 things at once. It's someone that's really good at like all those types of things. That's what executive functions are. It's something that we all take for granted. And so whenever they're not working properly, it can really be difficult and it can be really exhausting and it can cause dysregulation, which we'll talk about in just a second. Also, I know some of y'all on here are very familiar with the school setting. So if there's an impairment in learning, so your kiddos with an IEP, sometimes a 504, just depends on kind of which way your school swings on those types of accommodations, but your kids that have some kind of specific learning impairment, or they're getting pulled or maybe getting extra help in the classroom for reading or writing or math and such. Um, Also, memory. This is something else that I could go on and on about. So there's like three types of memory that we typically think of. However, generally we think it's like short-term memory and long-term memory. A strength that individuals with FASD have is long-term memory, but something that they really, really struggle with because of how their brain was developed is working memory and short-term memory. So your kiddos that you have to tell them a one-step direction 2 times, and you're like, why do I always repeat myself? It's because they have a really hard time with working memory. Or your kiddos that you've realized I cannot give them 3-step directions. I really have to make them simple, easy to follow, one at a time. Also, because they have difficulty with working memory. Or sometimes what we hear parents and caregivers say, it's like 51st dates every day. It's like we do the same routine every single day, and every day is a new day. Every day is a new day because you've kind of got all these things playing together here. But if whatever else is going on in their little bitty brain, their memory system could be affected. And then visual spatial skills. So our OT friends work on this. Your kids that have a really, really hard time with puzzles, that's kind of targeting this skill. Your kids that have tons of difficulty, or it takes them a long time maybe, writing down what you're writing on the board or following the instruction on the craft that you're doing for Grandparents' Day that you're showing them at the front of the classroom, having to do anything like that. When they get older, having to put stuff up in a cubby or having to locate their locker when a lot of stuff looks that way and they're kind of having to process and attend to whatever they're visually needing to get to. Those are those specific skills and examples of those in that neurocognitive impairment area. Second, and this is where Leslie always comes into play for our team, is self-regulation. So we talked about this earlier. Tiffany touched on this. It was that big, pretty graph where it's misdiagnosis, and a lot of times it's misdiagnosed for mental health disorders. So many of these kids come to us and we call it alphabet soup because it's like they are 9 years old and they have 9 diagnoses attached to their name. And you're like, oh my goodness. So a lot of times these diagnoses that are related to mood or behavioral regulation, this could be anxiety, this could be depression, this could be ODD or oppositional defiant disorder. This is a really popular one. Conduct disorder, DMDD. And then we also sometimes see some like reactive attachment disorder or RAD, and then PTSD and some of those. Also, this pretty much explains the behavioral symptoms that we see. And I'm really being intentional on the word behavioral symptom because we think a lot of times behavior is willing and they're doing it on purpose kind of thing. However, if you've got all these things going on, this is really a symptom of your diagnosis and a lack of support and understanding too. So this looks like what a lot of people, whether it's teachers or therapists or parents and caregivers, refer to as meltdowns. It could be they are aggressive towards other people or they harm themselves. Maybe they punch walls or they elope or they are destroying property, like breaking things. Maybe we get really verbal and things like that, or cry, and we can't we can't console, they can't soothe, they can't regulate those types of things in those moments of meltdowns. Also, we look at attention. So many of you have probably heard of ADHD, or previously known as ADHD, ADD. Now they've combined it to ADHD. A lot of times these kids come with us or come to us with either suspected ADHD or diagnosed ADHD. A lot of that's actually ADHD is the number one co-occurring condition with an FASD, because of just that hyperactivity and inattention that goes along with it. And then the last one is impulse control. So kiddos that have a hard time with fighting, or what we call confabulations, or what looks like lying, and then getting in trouble a lot because they say or act on whatever was the case when they were dysregulated and they couldn't regulate themselves, or even stealing. So a lot of that goes with impulse control, which is pretty much like stopping yourself before the consequence, whether it's a natural consequence or whether it's an emotional consequence of someone else or getting in trouble by someone else, happens. This goes with executive function. So all of these are like a domino effect in my book. Like I said, only one of these has to fit the child that we're evaluating. They don't have to have all three, just one of the three. And then the third box, or the third area, is adaptive functioning skills and showing a deficit in that. This one's different. So 2 of the 4 have to be checked off, is what we say, just to make it simple and easy. And at least one of those 2 has to be a communication impairment, so speech or language, where your speech therapy friends come into play. And then also, I should say, or social communication. So your pragmatics, your social skills, those mean the same thing. Your speech therapy friends also come into play for that. Then you have daily living. So this looks like, and it's different for, whatever age you are, but it looks at how you take care of yourself, how you get yourself ready, maybe how you can feed yourself, how you can take care of your environment, whether that's your room or your house, how you can participate and keep up with chores. There's so many areas that fall into daily living, but think about the day-to-day things that you have to do pretty much just to keep yourself going and, get to the next day and take care of whatever needs to be taken care of, to pretty much have functional living. And then the last one would be your motor skills. So 2 types of motor skills that you're probably familiar with: fine motor, which is where your OT friends would come in, and then gross motor, which is where our physical therapy friends would come in. If there's an impairment in fine motor skills or gross motor skills and the development of it and kind of how they're presenting in terms of, is it age appropriate or not age appropriate? That is another area for adaptive function. Okay, I'm almost done, I promise. Hang in there. The other 2 kind of boxes that we check off are symptoms. So any of these things that are showing up must present in a child before they turn 18, because that is our years of development. From birth to 18 is what it's classified as, years of development. So if you're like, well, does that mean they probably had these things going on all their life and maybe they didn't know about it, their doctor didn't know about it, and now they're 27 and they can't hold down a job? Do they just not get a diagnosis and they don't get services and support? No. You can be diagnosed at any time in your life. However, there's got to be evidence or history, really, that you were showing these types of symptoms in these 3 areas while you were growing up until you turned 18, kind of thing. So it's where that line kind of happens is you can't turn 18 and you can't be 24 and start seeing these things occur, but you never had difficulty with them growing up, kind of thing. And then the other one is that it's causing distress. Our rule for our clinic that we always say is if you are here and you traveled to Little Rock to see us, it's causing distress. But if someone has referred you for this diagnosis, or if you are, struggling in school, or maybe home, like it's a constant battle at home of getting yourself ready for school or doing homework or whatever. Maybe it is difficulty within your job, if you have a part-time job or a full-time job, that is causing distress. And so that would check that box in terms of this diagnosis. Any questions about this before I move on? I'd want to make sure. Okay. I know Tiffany and Leslie are doing a good job at managing that, but okay, so we're about to wrap up and get into questions. Before we do, if you don't mind using the camera feature on your cell phone to scan that QR code, and just whenever that link comes up, click it. This is for our job and what we do. It's easy peasy, 4 questions that you just select your response. If that's not working for you, I will I will put that link in the chat some way, somehow. Yes, whoever just said that in the chat, it is very common that they have these symptoms and these difficulties, and it's not diagnosed, or it's misdiagnosed. Another part that I love about our clinic is we work with a self-advocate, so someone that has been diagnosed with an FASD, and she was not diagnosed until she was 37 years old, and she does the most phenomenal job at connecting with the client, that's the child or the parent and the caregiver, of really painting that picture of what it was like to grow up expected to be neurotypical, and just constantly feel like she was battling, what everyone expected of her and what she was required to do at home and at school, and what was going on inside her brain and inside her body. So yeah, great point. Oh, about the before they're 18, that type of thing, Dixie?
Yes.
Okay. No, you're fine. Let me go back. So you can be diagnosed at any time, no matter what age you are. The symptoms just must be present before they turn 18. So like a lot of times if we do see an adult client, which we don't really a lot, but within our clinic we have, they would have to say like, oh yes, when I was in school, maybe I got pulled out for reading. I had a learning impairment, and then maybe they have a diagnosis of ADHD, and they got that diagnosis when they were 12. Oh yeah, I was in speech therapy until I was in 2nd grade, and I was also in OT until I was in 1st grade, that kind of thing. So those would be like, okay, well, those symptoms were present before while you were growing up, while you were developing. And so if they were 45 at the time, and then that diagnosis could still be made. So it's just when those symptoms are shown, has to be before 18, but that a diagnosis does not have to be given before they're 18.
Thank you.
Yeah, you're welcome. Great question. Okay, oh, let me go back in case y'all didn't have time to scan that, and then I will show you, not that, our contact information.
We have another question here about misdiagnosis. Do we have a number on that, Natalie, on the number that are misdiagnosed? I don't know if we have an actual number, but it's something that we hear frequently. I know a lot of the allied professionals that work in the schools are like, I have this kid, they have an autism diagnosis, but it's not autism. And so it is something that happens often. Tiffany, do you have any numbers on how many are misdiagnosed?
No, that data doesn't exist, and part of the problem is because we're just realizing how big of a problem FASD is, how high the prevalence is. And so now we're just starting to look at kids with autism and see could they actually have an FASD. And so I think that data will come out in the near future, but it's not data that's available right now.
It's definitely something that schools, I have a PT friend that's like, there's so many kids that have this diagnosis of autism and it's not autism. So we do hear that a lot.
Yeah.
Now's the time for questions. If anyone wants to unmute and ask the three of us questions, or you can keep putting them in the chat if you prefer that. That's totally fine.
This is Amy. I was asking about the misdiagnoses, and it makes me wonder if that's why they went from saying they're in the upper level spectrum versus now it's called the autism spectrum disorder, that they're realizing that it's not as black and white.
Yeah, the thing that we run into is that there is overlap with autism and FASD, and there's nothing saying that you can't have both. However, that's not super common to have both. A lot of what we see is the misdiagnosis because of the overlap. And I think that's something that is like what is like the new topic and the new big question. So I think that that would be something beneficial for us to cover in session 2 because it is interesting to do that side by side comparison. The other thing with that is, if someone comes with an autism diagnosis and we give an FASD diagnosis, and the parents like, I feel like this explains my kid so much better. Is this something that like we should have autism taken off? That's always kind of a big burning question too, because if you look at the education and the resources that are there for an autism diagnosis, that's what's like really hard because the parents like, yeah, but when we got that, it opened all these doors for therapies or, accommodations in the school and such. And so we always make that the parent's choice because that's always a big hot topic whenever autism and FASD get brought to the same conversation.
Not to mention the stigma as well.
Absolutely. Absolutely.
Yes, and we have quite a bit of information on the overlap. I have done that in previous presentations, so I'll make sure that that gets included in the next one.
Yeah. Great question, though. Oh, perfect, Janice. We're in the like I said, our part of the project is educating and training practitioners across the state to do this. So hopefully, whatever area of the state, we're all across the state. So whatever area you're in, hopefully we're going to have a team in your backyard to get this diagnosis for that kiddo that you're helping. I know every time I do one of these trainings and presentations, people are like, oh, I could like start naming off. And especially like if you're in a school setting. Oh yeah, okay, you're in Horatio, perfect. If you're in a school setting, then you can name a lot. It's like we said, 1 in 20, really maybe 1 in 10. So it is prevalent in every single classroom.
How much success have y'all had? I don't know. We were talking about the stigma of it and bringing that up to a parent.
Yeah,
You know,
so
you understand? Yeah.
yes, absolutely. A lot of times that is where that, and I'll go back to it.
Well, and One thing that we are
Okay.
teaching the providers in our training is how to approach it with parents. So the American Academy of Pediatrics has a simple 3-question kind of thing that they recommend to ask, which includes like, what were your drinking habits like before you got pregnant? How far along were you when you found out you got pregnant? Did your drinking habits change after you found out? So there's ways to ask without being as stigmatizing or making them feel bad. It's just getting that information out to providers and getting them to ask those questions.
Yeah, or like slipping it into case history. You don't have to verbally ask and have that face-to-face interaction that can be so hard because a lot of times it's intimidating to go to the doctor and them ask about any aspect of your life. So we've loved to have that option. And then the other option is that unspecified neurodevelopmental disorder. Um, so there could be suspicion of it, especially like a birth mom that's like, I don't know, or they don't, because of the stigma, they don't want to come out and say it. If we can match the symptoms, to the fact that neurodevelopment was, affected, then it could still provide them with a diagnosis that would be, not as stigmatizing or not stigmatizing at all, depending on, um, their beliefs and their outlook on that.
And in our clinic, we see a high population of adopted kids, of foster kids, and then we've also seen a lot of kids that might be with a biological parent, but the biological mother is no longer in the picture, but they have that history. So there's ways that we can that we get that we kind of get around that.
Yes. So Stephanie asked if FASD trainings are being required for medical providers to help the children and the families. So what we've been talking about is we're, spreading this across the state. So these teams that we've identified, consist of a medical provider and allied health providers like your therapist and things like that. And they are a team and they are going through multiple what we're calling modules or just trainings that covers FASD, symptoms and medical conditions and diagnostics, pretty much how we diagnose these, individuals, how they can replicate that and do that too. So it's extensive training that they're having to do in order to make these calls, but also to know what to recommend in terms of medication. That's something that Leslie deals with all the time. Appropriate therapies and what are, like evidence-based approaches. What are things that these kids really need in a classroom and school environment, that might have been great for a kid with ADHD only, but maybe not a kid with FASD that's not just dealing with attention deficit. But these other areas as well. Yeah, great question though.
Yeah, and it's not required for all providers. It's the providers that are doing our pilot program. However, we have seen a lot of the kids that we do see in clinic, parent will take that report to their pediatrician, and it really sparks interest in those pediatricians, on getting educated about it and finding out. And we do provide resources, in our reports that we provide to these families with all kinds of training information and things like that for the families that they can also share with their personal providers in all areas.
To kind of follow up on that a little bit, just to go back, if you look at medical school curriculum, there's no requirement in curriculum that FASD be covered. So there is a requirement that they have to cover like typical and abnormal development. And so some schools provide FASD training more than others. Here in Arkansas, students get one slide on fetal alcohol syndrome. So just the type with the facial features. So hopefully that will change someday as well.
Great question, Leslie. That's another thing that we're hoping will happen. It's something that we still hear all the time, that there are practicing OBGYNs that believe that they're, whatever certain times in development, or just red wine doesn't hurt. Stress is more harmful to the baby, so just drink a glass of wine, or have a bottle of beer to just take the stress off, because that stress would be worse than alcohol. Definitely seeing it on our side from like the pediatrician, primary care, family practice. So I think the next step would be targeting that OBGYN population, because it's like we've said, they'll ask about drugs, and if that's confirmed, then that's all that they'll ask. I know in appointments, it's like they just ask about the here and now. Are you like if a woman goes and she's pregnant, are you drinking right now? And that's all that's asked. It's nothing about, well, before you found out you were pregnant, because I mean, a lot of times it's, oh, we missed a period, so we're 4 weeks in, kind of thing. Or if we missed a period, then it'll come and maybe it's at 8 weeks and we're like, oh man, now I'm at week 2 of a missed period. Maybe I do need to test. And so Tiffany and Leslie might have more information on what's being done in the OBGYN world. On our side, we're at that level, the primary care side of doctors, but I think that's where the prevention, more of the prevention kind of agenda will come into play.
Something we see more on the pediatric side is these babies get labeled as drug babies because they were positive for drugs, and alcohol was never even asked about, and there's really no way to test for it. And so they may get into their teens and no one's ever even asked them about exposure to alcohol prenatally. And so we've seen that a lot, where they think all these issues are drug related, and there could be some issues, but we have, as Tiffany mentioned earlier, alcohol's the worst teratogen. And so we see a lot of kids that's never even been identified.
Yeah, and like Tiffany just mentioned, their professional organization, their guidelines say there's no safe amount, but it's up to the individual provider to really implement that and educate that in their patients. Tiffany is part of the Arkansas None for Nine, which is a state level organization that does a lot of work with FASD. And one of the things that they passed, and the next time that y'all see this, you should send them an email. In a restaurant that serves alcohol or a bar that serves alcohol, those establishments have to have a sign up in view of customers that has the warning of, if a woman that is pregnant consumes alcohol, it may cause birth defects, is what I've seen. So that was something that local organization has pushed to kind of help with the public education. But then, it's like if an OBGYN is telling you, oh, it's okay, then it's like, okay, who do I believe? And that kind of is where it gets tricky. So hopefully that education and that guideline will be implemented at the level of the practitioner. Any other questions? It's 7:08, so I want to be respectful of everyone's time. I know it's a Thursday night, so if you want to drop it real quick, or you can unmute and just ask it out loud. Otherwise, I think we will close down at like 7:10 if that works for everybody.
And also our emails are on the presentation slide.
Okay.
So if you think of anything or have any questions for us or need us, you can get us through there.
So glad y'all attended. And like I said earlier, if you want to learn more about Partners, the program that we work for with the U of A, here's our Facebook link, and then our website. And then if you are on Twitter, or now X, then we are also on there and share lots of information, not about just our project, but the multiple projects that Partners does. Okay.
Thank you all so much.
Yeah.